Well, here we are, another episode, and we're back from a break. Isn't it great to be
I
back,
know.
Renee?
It is great to be back. It's kind of crazy. On one hand, we went through what, a year and a half of recording and didn't take a break. But this year, we both just needed some time off. So good to be back. I'm hoping everybody enjoyed that three-part series that we did on workplace mental health, and got some great ideas. But we're excited to be back today. So what's going
Absolutely.
on the farm? We're at the end of March.
It's
Aren't you talking about
spring
starting to
and it's,
plant?
well, it's muddy. You always get that spring
Oh.
mud where, the frost comes out of the ground. It happened earlier this year, but it's just a muddy mess, and I'm just tired of it.
Well, but you can't be that sad, right? I mean, so what'd you get to do when you were out and about on vacation? I mean, I think we've talked about this before. Something to do with spears and fishing. Yeah.
Well, there's always spearfishing. That's like a spring break tradition. So,
Oh, okay.
um, you know, maybe in a future episode we could reflect on those activities we do for self-care on vacation, because
Maybe.
that's always something to celebrate.
I don't know that I should be ever given a spear for self-care or
Well,
to help my reducing stress. I might actually be dangerous. And so maybe for me,
yes.
that's not the coolest. But I got to just sit on a beach and read books, which for me, that's actually the deal. So all about that. Well, today we're going to be talking about starting a new series. We're pretty excited about this. We put this series together for critical access hospitals in the state of Illinois. Actually, they were doing a series for pediatrics and some of the challenges in rural health, and they asked us if we would be part of that. So we're going to share with you what we've learned through our deep dive on pediatrics, and not just our state, but in Illinois and other states that we've been working in. And so we're going to be talking about those behavioral health emergency departments and some of the challenges and opportunities. And then over the next 2 or 3 weeks, we're going to be diving in deeper on specific pieces of this, which I think will be really helpful to those listening. As we know, we're still in a big kind of redesign part 12 in the state. I don't know. And so there's some challenges, right? And there was just this big settlement about kids in our state not really having a good system. So there's a lot to be worked on and a lot to do. So as we dive in today, Jason, kick us off. What are we talking about here? Give us an overview of what's going on in emergency departments and what are some of those challenges we're seeing out there?
Yeah, I mean, I think let's just start with where we find ourselves today, especially in rural hospitals. We spend a lot of time in critical access hospitals and talking with critical access hospitals. And, I've had the opportunity just in the last couple of months to travel to several critical access hospitals and sit with leadership. I just came off of sitting with a mental health forum that occurred in my own local community where local hospitals came together. And guess what? The shared issue that came up was boarding in emergency departments. How do we manage violence in emergency departments? How do we manage the mental health need? And
Right.
we're overwhelmed. Those are the common themes that I'm hearing, not just in Iowa, but we hear it in Illinois. We hear it when we go to the Indiana Rural Health Conference. We hear it when we go to Nebraska, when we were doing work in Nebraska last year. It's the same issue. And I'm not hearing a lot of solutions. I'm actually, as I hear more, I actually get a little frustrated because I still hear that disconnect between healthcare and behavioral health care. And I struggle with that a great deal.
Yeah. I mean, and even other states that you didn't mention, we've had conversations about where kids ended up going home with HHS workers or having to spend the night in offices or being put up in hotel rooms. I mean, it is, and that's not just this year. That's been in previous years past. And so we've been talking about this issue for decades. And the people that are on the front lines that may be listening today, they know this is a decades thing. I mean, we all know this is the reason I ran for office over a decade ago now, was to fix the children's mental health system. And so it is very frustrating when we continue to hear these issues and the fact that kids, especially kids, are getting still stuck and parents don't know what to do, where to turn. We still have these rules where maybe parents have to give up their rights in order to access care. I mean, it's just a hot mess. And so we're going to be talking quite a bit about that today, and maybe talking about some ideas of solutions or things that we know could work, even though maybe they're not now, because Jason and I know that there is a system of care that should be working for children. And so it exists, it should be working. And so there's pieces that are like, you do have hope in there, but sometimes it just gets so frustrating because you just can't get that access that you need.
Yeah, absolutely. And I think, what we'll dive in deeper as we talk about some of the upcoming episodes But we'll do some compare and contrast. Let's think about what do we do for the Medicare population? The same providers who complain about not having availability to mental health resources or not knowing how to do care coordination or not knowing how to connect, or one practice says we don't do mental health. We just
Mm.
refer that all somewhere else. In a follow-up question, then talked about how successful they are with managing at-risk 25,000 Medicare payments because they get paid to provide care coordination and divert people from the emergency room. And the same organization talked about how successful they were with managing someone's whole health. And so that's where I get really frustrated because I'm like, well, on one hand, you have an entire population that you're managing and you're telling us how successful you manage by diverting people from emergency departments, how you help with nutrition, that you assist, in reducing falls and looking at social drivers of health. So in this population, you can figure out how to do it, but yet with young people, with children and adolescents, or with people with mental illness, you have no idea what to do. And so I think that's kind of disingenuous when I hear those conversations. I bit my tongue and I didn't ask questions at the end. So you should be proud of me, Renee. I thought I'd better not stir up too much trouble in the room that I was in. But I think that gives us pause and an opportunity to look at what can we do differently.
Well, and one of the things that you and I both know is children aren't just small adults. And you and I have been on that bandwagon for years and years and years. And as the system continues to quote streamline and to quote redesign, that's getting lost in that shuffle. And what works for children doesn't work for adults and vice versa. And so what we're getting is everything blended together. So it's not working for anybody, right?
Right.
It's not adult specific, it's not geriatric specific, it's not child specific, and it's becoming very watered down approach that's not helpful to anyone in specific. So that's very disheartening when you start to hear some of those things because people are just getting boarded and backed up. So let's talk about some of the data now, Jason. What are some of the data that we're seeing, and how do we know data wise that this is actually a growing problem and not just an ongoing situation?
Yeah, and so we have a lot of data leading up to the pandemic, and this has been kind of a struggle as we went and looked for data to validate some things. Is the pandemic really skewed our data? And so when we think
Mm.
about those data points between, really 2020 to 2023, things really got out of whack. And now as we look at what's going to happen to data, we're going to have less data in future years because of that delay in data coming to us. And right now we have such huge restrictions in research that are occurring for some of these areas. So we're going to kind of be flying blind, I think, in 2025 and 26, unless we find different ways of gathering real-time data. But we know looking back in the last decade, visits to emergency departments for suicidal ideation or behavior have increased at least 31%. From 2007 to 2016, we saw mental health visits for kids increase by 60%. And these are mental health visits. And so 32% of those kids who went to the ED received an outpatient mental health visit within 7 days. And like 50% maybe received, had a therapy appointment follow up within 30 days. And so as we kind of go through this, then what we really tune into is what's the return rate to the emergency department. And it's
Right.
about a quarter of those kids, 1 in 4, will come back to the ED because they didn't get the treatment they needed in the community on an outpatient basis. And so that's part of why we're seeing our emergency departments get bogged down in the mental health crisis, is because what's happening to the kids? How are they being connected? Are there warm handoffs? What is that system of care? And that's really going to be the focus, and that's some of the work that we're doing right now, is helping communities to recognize how can the hospital be the convener. And that's really what we're going to dive into as we go through this series, because the solutions that are out there right now aren't working. And so we've really got to think outside of the box and figure out where is our funding going and how are we leveraging what we have, because new stuff isn't going to happen. We're not just going to create care coordinators and social workers out of thin air. We got to maximize what we have and make the most of the efficiencies that we can.
Yep. And you just stepped on one of my favorite soapbox issues, right? Because you just told me that kids went to the hospital for crisis, and then you said that the data that they tracked was an outpatient appointment.
Yep.
Okay. I mean, if you go to the hospital for a heart attack and they hand you a card and say, please see your cardiologist in the week or in the month or in the next 6 months, you could be dead. How in the world are we treating mental health like it's not the crisis that it is for these families and these children. And to hand them an outpatient card is just so sad. That's the best you could come up with, and that's the data you tracked. That's just not good. And I don't even have to go past that part, right? It's just that's just a mess. And if you're in crisis enough to have to go to the emergency department, you need something more intensive more quickly than an outpatient card. That's not, I mean, oh gosh, that was awful.
So
And I know it's just bad.
even worse than that, to get that outpatient card, you had to sit there twice as long as someone with a
Ugh,
physical health issue. It took twice as long just to get a referral to an outpatient clinician that would maybe be 7 to 30 days from
right.
today. And so I think that's the bigger issue, right? Is it's taking longer for really a no result, for
Right.
not helping the person who's experiencing a mental health crisis. 1 in 5 of those visits lasted longer than 24 hours. And we hear anecdotally from our local hospital that it's not unusual for people to be held in the ED for over 72 hours, both
Yeah.
children and adults, because the system just doesn't have the capacity, the throughput to move people through. And, that's a big part of what we do is we talk to systems, we talk to states about how do you increase capacity just by moving people through the system, through the continuum of care that you're supposed to have funded and are supposed to be supporting. It's not about adding new, it's about using what we have and maximizing efficiency. But no one wants to talk about that, Renee, and it's so frustrating to me.
Yeah, I remember at that SARL conference we were at back in January, a lady walked up to me after I spoke, and she was she worked in voluntary as part of like the emergency response team of some kind. And her feedback to me on that day was just about the folks that come in this situation in the ED. And she says, if somebody comes in crisis, almost for anything else, there's 4, 5, 6 people helping, attending them and working on them and helping them. And she says, but somebody comes in with a mental health issue. She said they're likely to be one, they're lucky if there's one person that sits with them or talks with them or kind of they're just sort of stuck there with nothing. People just like their brain shut down and they can't figure out what to do for somebody. So they do nothing. And so she says that you could just tell, like walking into the ED, who's got a physical issue versus who has a behavioral health issue. She said by just looking at how the staff behave, who's showing up, who's coming to help, how many people are helping, they just sort of just set them there because they don't know what to do with them. They don't know how to help. And so they just sit there. And so to your point, then that makes so sense, right? Because if you're waiting for the one person in the hospital who might know something to be able to help you, you're sitting 10 times longer. You're just going to sit there so much longer because then you have to wait for that one guy who still might not know anything and still may hand you the outpatient card, which is useless, to show up to let you back out. And so
You,
it's just so frustrating. And so even the people, who just work in the field can just tell. They you just by looking at how the people are treated and know what the issues are.
what you kind of hit on, this is a good transition kind of into our final talking point of kind of what the issue is, and this is kind of where we're going to start laying out some solutions over the next 4 weeks of kind of what can you do about it. And it starts with policies. Like,
Yeah.
how do you manage, most conditions within an emergency department or a hospital setting, even a primary care clinic, we have what's called clinical pathways. And we've
Yep.
developed these for behavioral health organizations so they can talk the medical healthcare language, right? Because this is one of those gaps between behavioral healthcare and healthcare is we don't talk the same language. And really it's having a documented process in place. And that's really important to have. And I came across a study in 2021 that only 46% of emergency departments had a pediatric mental health care policy. So any guidance at all provided to their staff in writing, only 46% of emergency departments, that's less than half, right? So it's no wonder people don't know what to do because we're not giving the staff, we're not giving the nurses what they need to do their job. And remote areas and rural areas, 60% less likely to have a policy than urban areas. And so we think about our rural communities, those rural hospitals, they have the least amount of tools. We're not providing them any of the tools that they need to support families of children with mental illness or to support
Mhm.
those children who are coming to the emergency department in crisis. And so I think that it's kind of a good starting place as we start to think about the conversation. If we don't even have a plan in our local hospital or a local clinic, then how do we expect the physicians and the nurses to have any roadmap of where to go in their community?
I agree. And what you end up with is what we've talked about on other podcasts about people just sitting there with people sitting next to them that they actually call sitters,
Right.
where their job is to sit and just be there with them because they don't know what to do with them. They don't want to leave them alone, but they don't really have the right level of care. They don't have the right people there. And then, as you and I both know, that sitter is the absolutely wrong person to be sitting there. And we can go on to a big soapbox about that too. But, whether you should, there's so many opportunities. I hope we dive into more when we as we spell this out. But just the use of peer support in the
Yep.
emergency department would go so far to fix so many of these issues. They can't fix everything, but that been there, done that situation would just help calm the family, help calm the client, and give them some hope that they can get better. And that's a very low cost solution that could be done in any emergency department with trained people who've gone through these experiences, who are on the other side, who want to give back. And that's just one of many things we can dive into to talk about what to make this better. But I just wanted to make sure people knew that there are opportunities, lots of opportunities for improvement. We just have to put these pieces together because nobody, like Jason's always tells us, nobody's talking about this. So they don't realize how easy it would be to find a solution.
That's absolutely right. And training is the pinnacle part of that, Renee. I
Yes.
just want to go back to what you said about training. When we go in and we hear these stories about sitters, I ask every time I'm in ED, who do you have come over and how are they trained? Do they have the tools to be here and what resources? And so that's going to be a key part, right? And training that comes from policy. I know we talk about policies a lot. I think it's in our name. This is why we talk about policies, because we know if it's not written down, it's not going to happen. And so the
Mhm.
next 4 weeks, we're going to talk about how do you formulate and write something down so it means something. You can train on it, you can disseminate it through wherever you work, healthcare organization, behavioral health organization, community-based organization, whoever you are. If you write it down and have a plan for executing it, then you create a better opportunity for the people that you serve. And so this is my soapbox, Renee. I get kind of passionate about it because we've got to figure out how to write stuff down and make it meaningful and then actually execute and implement. And that's what I spend so much time doing that. But I think that's what we got to do at a much larger scale because we're doing it from community to community, from hospital to hospital. And it's like creating the wheel every time we walk into a different town and do the same thing. And although that's great because I can go in and look great at that next small town, it gets kind of repetitive, Renee. Like, I'm kind of like, could we just do this once and be done? I would be fine to be out of a job if we could like just get this done and then I can move on. I'll find something else. But I think that's the challenge right now is how do we really start to make a change at a much higher level?
Agreed. Well, for everybody listening today, the self-care policy of the week from the recovering politician is vacation. You just heard Jason and I took some time off here in March. Thank you all for continuing to listen. But vacation can look like a lot of different things. I had a friend who had a lot of home projects they were working on and needed the time to make some real good headway at home. And so instead of leaving on his vacation, took the time away from work, still got to be at home with the family, but then just worked on house projects through that time. So it doesn't always have to be, going places and spending money. There's maybe a lot of us this year, that's a little tighter than it used to be. And so, you don't have to make it a big vacation. Jason likes his big spring breaks, and I have no fault behind that. But other people, maybe that's not your thing. Maybe you don't want to do that. But just taking time away to be able to think, to get your head clear, to get out of the office, to spend a little time. And that could be at home on your couch reading a book and would still be just the same. So, but the important part is making sure you take that time because Jason and I, we talk about this, and I'll put that little note right here, but we always go to conferences and ask people to raise their hand. How many people have over 2 or 3 weeks of vacation saved? And it's a majority of the place where they don't use it. They pay you to not go to work. You should utilize that piece of information and utilize that gift and use it for your benefit. And so I'm talking about vacation today because it's important whether you do it. I've got one lady in my office who does it. I call it the mini vacation, but she'll do an hour here, there, 2 hours here, there, all the dang time. And then occasionally take a bigger couple of days. But she just likes to have, the afternoon off early or the Friday off early or come in late on a different day or whatever. And that's how she uses it. awesome. I mean, it gets her what she needs. And other people are like, I save it all up and I have another coworker going to go on a 2-week pilgrimage to Rome in the summer. He wants to do a big thing away. Great. But they're using it. So, right, it's all about using your time that you're given and so that you can be off. So hopefully everybody, you all too, get some opportunity out now that we're hitting almost spring and the time has changed and now that it's light outside, get out and enjoy it. So today we talked about our beginning part of the 4-part series to talk about emergency departments and about children and pediatrics and how the system is kind of stuck. It's not really working the way we want it to. We're not even sure sometimes that there's a vision to make it work very well, but we're going to dive in over the next few weeks and talk about all the solutions and the ideas of basic things that you can do if you're in this system to make this better. But before we go, don't forget to follow us on LinkedIn, Facebook, or Twitter. If you leave us a positive review, we'll send you a prize. Jason's got those prizes right there. Have a great day, everybody. We'll see you next time.